Hello and welcome to everybody who's watching across the globe. Today, we have a very special topic, managing complex corneal disease, alternatives to traditional transplant. And I know how important this is to the plethora of women experts that we have today. Neil, sorry, you just added in, buddy.
I'm in good company.
Thank you, Neil. But before we go ahead, let me introduce before we go ahead and introduce the experts, let me introduce the series. The Rising Stars in Ophthalmology. It's a 9-episode series per year. Each of these episodes will usually star one rising star and surround them with 3 celebrity panelists. Now, these are the backbones of ophthalmology who really, have the plethora of subject in their system. This is an interactive discussion. So audience members who are watching, please throw in your questions in the chat window, both in the YouTube as well as the website. We are live on risingeyestars.com and our YouTube channel, Rising Stars in Ophthalmology. Obviously, because it's a global event, you can watch the reruns on our website. Also, don't forget to watch out on our social media, Facebook, Twitter, LinkedIn, Instagram, because that's where you'll get some educational tips, which we take out of each episode in the form of snippets and tips. I'd like to thank you all personally for tuning in and thank the sponsors for making this happen. Now, to do the honors, can I please call upon Jen Lowe, who can introduce our sponsors, celebrities, panelists, and speaker. Jen, all yours.
Thank you so much, Ashwin. And once again, it's such an honor to co-host with you. Before I get started in introducing our celebrities as well as our rising star, I would like to thank our sponsors for the season. And our season 2 sponsors include Allergan, Elcon, Visus Therapeutics, Avellino, Dompe, Sun Ophthalmics, and Tarsus. I would like to give a special thank you to our episode sponsor tonight, which is Dompe. And speaking on behalf of Dompe, we have Dr. Neil Desai, who will be saying a few words. Thank you so much for being here, Neil.
I think it's a tremendous honor to be a part of this group. And I think Dompe certainly shares the feeling of privilege of being able to sponsor tonight's program and the entire series. It's a phenomenal series that you guys have put together here. I think we're all familiar with Dompe and have been introduced to Dompe in the context of its work on providing us a phenomenal, innovative treatment for what was considered at one time a rare disease state with a very unmet need in the form of neurotrophic keratitis. And so oxervate has been tool in our toolbox for the treatment of neurotrophic keratitis. But what we may not know is that Dompe has been around for a long time, and it's an enormous drug company and a very innovative company in its own right, internationally and globally. 200 different research centers have worked to bring Rita Maltolcini's work to the forefront in terms of the discovery of nerve growth factor. But they've got a robust pipeline, even beyond ophthalmology, in terms of novel drug development and new molecule discovery, powered by not only powerful researchers around the globe, but an AI-backed drug discovery platform. And so I think it's very fitting that Dompe has volunteered to sponsor this whole series, and particularly tonight's episode. And its innovative speaker, Priya Mathews. So I'll hand it over back to Jen, and looking forward to tonight's program.
Great. Thank you so very much, Neil. Now I'm going to go ahead and share my screen in order to introduce our tonight's panelists and rising star. So again, welcome to episode 6. Entitled Managing Complex Corneal Disease and Alternatives to Traditional Transplantation. So first on our celebrity panelist list, we have Dr. Deepi Dhaliwal. As a little introduction, she went to Northwestern University for college. She did Northwestern University for medical school. residency at the University of Pittsburgh, and a fellowship as well at the University of Utah. She's currently a professor of ophthalmology at the University of Pittsburgh School of Medicine and the vice chair and division chief. A fun fact about Dr. Dhaliwal is that the meaning of her first name, the first part of her name, Deep, means light, and Inder means queen or king. So she is officially the light queen. So thank you for being here tonight. All right, next up we have Dr. Sumitra Khandelwal. She went to college at the Washington University in St. Louis, medical school at University of Texas in Houston, residency at Emory University, and a fellowship at the Minnesota Eye Consultants. She holds a current position as an associate professor at Baylor College of Medicine. And a fun fact about her name here, sorry, I was trying to see this, is that her first name means good friend. And I would definitely say she always lives up to that. So thank you, Sumitra, for being here as well. All right, so last but not least, we have Dr. Audrey Talley Rostov, and she went to college at Boston University. She did preclinical. Prior to med school, she actually did a research fellowship in ophthalmology at Harvard and Mass Eye and Ear, medical school also at Washington University in St. Louis, residency there as well in WashU. And now she's currently practicing, she did a fellowship in Minnesota Eye Consultants, and her current position is the director of cornea, cataract, and refractive surgery at the Northwest Eye Surgeons in Seattle, Washington, and she's a partner and owner. A fun fact about Audrey is she often goes running and stand-up paddleboarding. So thank you to all of our celebrity panelists. We cannot do this without your expertise and time, so thank you. So to introduce our rising star tonight, we have Dr. Priya Mathews, who many of you probably already know. She did college at the University of Maryland, medical school at Johns Hopkins, residency at Columbia, and a cornea fellowship at Wilmer Eye Institute. She's currently practicing at Florida Eye Specialist and Cataract Institute, but she will be transitioning the Center for Sight shortly. Okay, so at the very end of our introduction, we always like to allow the rising star to share some photos, fun photos of herself and her life. And I'd like to give you the floor, Priya, to kind of describe some of these photos for us.
Thank you so much, Jen, for that introduction. So in the top left, those are all my co-residents. This is when I was a second year resident at Columbia. So I did the forbidden, which was fall in love with my co-resident. So there's pictures on the right, which is Joaquin, my co-resident, who I ended up marrying our senior year of residency. Bottom left is my class. All of us are scattered all over the country now. Those are some of those pictures, yeah.
Okay, great. And I see it. Okay, and here's I think the last set of photos.
Yeah, and so this is a little bit about our travels. So we love traveling. After fellowship, we spent 2 months. We traveled all over Spain, and we went to India as well. So right before COVID, actually. So in 2019, we took 2 months off and went around the world and loved it. So it's a few pictures from our journey.
Wonderful. And I think the last set of photos shows some pretty cute new additions.
That's right. So we had a baby girl, Isabella, in 2020, and then 2021, end of last year, 2 months ago, baby boy Leo, who was born in the bottom left. So it's been quite an exciting 2.5 years since we finished training.
That's amazing. So cute, adorable family. Congratulations. So, all right. Well, I'm going to stop screen sharing now, and that'll let you pull up your slides.
Great. Okay, so thank you to everyone, for the organizers, for the Rising Star series, for this opportunity. I'm really excited to present something that I'm very passionate about, and along with the celebrity panelists, and to hear their thoughts as well, and the moderators. And thank you to the sponsors as well. I'm very excited about this. So I'm going to be talking today about managing complex corneal disease, alternatives to traditional corneal transplantation. So my financial disclosures. I'm going to go through a little bit about how I got interested in this topic of corneal blindness, the current limiting factors, some alternative options for corneal transplantation, and we'll go through some case presentations toward the end. So my introduction to public health in ophthalmology started in medical school. So I was at Johns Hopkins, and I independently became interested in both ophthalmology and public health through some medical missions that I went on in the beginning of medical school. And then I met a group of faculty members within Wilmer Eye Institute that were part of the Data Center of Preventative Ophthalmology. And this was very transformative for me because I saw how you could integrate public health and ophthalmology together. And it was founded by Dr. Al Sommer. There's a picture of him here, and he's best known for his work with vitamin A deficiency and the role that it plays in childhood morbidity and mortality. So I decided after my third year of medical school to just take a year off and pursue a master's in public health, also at Johns Hopkins. And my thesis mentors were Dr. Asanakpek, who's a cornea specialist, and Dr. Pradeep Ramalu, who's a glaucoma specialist. So that was a very fun year where I learned a lot about this intersection between public health and ophthalmology. I also went on several other trips that year. Here on the left, this is my trip to Bolivia. Here I spent a month in India, in Mumbai, and in the top right, this is Haiti. And all these trips, I kind of realized the difference between, going on a mission trip and actually being involved in public health. How was I going to think of a problem that I was very passionate about, develop solutions for it, and then think about how it could sustain even after I left or went back home. And I was looking for my purpose within the public health ophthalmology. So fast forward a few years, I had a senior year trip to Guatemala, and this is where I actually found what I wanted to do. Here's a few pictures from our trip. So this is the first time that I really saw ophthalmology in a public health setting. And in the bottom left, we have a picture of the Guatemalan surgeons as well as the American surgeons. And Dr. Lisa Park was my attending at Columbia, and she's the one who took us. And it was really a wonderful trip to see how different the pathology was there, but also the treatments. And you did what you could. They were very skilled surgeons in not just one specialty, but in all the specialties. And as a budding cornea specialist, I knew I wanted to go into cornea at that point. I'd already matched for fellowship. One thing I realized is that there was so many corneal ulcers, and not just tiny ones like the ones that we typically see here, but really vision-threatening corneal ulcers. And multiple came in every single day. And when I started seeing these patients, I started asking the surgeons there, well, what are we going to do if these conservative measures don't work? And that's when I'll never forget this feeling when I was asking them about their eye bank and how we get tissue. And I realized that the whole country of Guatemala did not have an eye bank or access to readily available corneal tissue. And they really relied on, sporadic donations that came from the United States, or when a surgeon visited, they would bring tissue along with them. And this is not just a Guatemala problem, this is in Latin America, and I found out later, a lot of the world does not have access to an eye bank. And that's where I really found the problem that I felt passionate about. And this was about 4 years ago. So how do we treat corneal blindness in countries with limited resources or no access to eye banking? With corneal blindness, it's a little different. There's only so much medical treatment you can do. Once you're to the stage of blindness, you really need surgery. A little background about corneal blindness worldwide. So according to the World Health Organization, corneal opacities are the third leading cause of blindness. Sometimes it's fourth. So ahead of that, we have cataracts, glaucoma, and sometimes macular degeneration. And all of these diseases are really more of a disease of the older population. But corneal opacities, corneal blindness, what's different about it is that it really begins at a young age. And that has implications for that individual. They're going to have to live with it for several decades, and for society, because it affects their productivity. Worldwide, there's 12.7 million individuals estimated that need a cornea transplant, but only one cornea is available per 70 needed. And the statistic that I find just very, humbling and staggering is that more than half of the world's population has no access to corneal transplantation. So our first question to Dr. Dhaliwal is, do you think that a priority list should be created in countries with limited cornea tissue? And if so, what factors should be taken into consideration?
Well, first of all, thank you, Priya, for this really kind of inspiring presentation. And your background, your passion, you're definitely a rising star, and it's exciting to meet you in this format. So, global corneal blindness is a huge problem, as you state, and limited resources have to be used effectively. So you have to look at so many different factors. I mean, who is going to be the judge to say you're going to be able to see and you're not, because we only have one cornea, right? So this is a very challenging ethical question. And, it's really nuanced. You have to look at the whole history, what's the status of the other eye, what's going on. Are these patients going to be able to take care of the transplant as well? So you have to look at the whole, support system and everything. So it's not just, the pathology and eyeball and should this, person get a transplant or not. You have to look at the whole, big picture. So ideally we would be, and hopefully we're going to talk about, options to decrease this need for corneal transplantation with different types of innovation, or increase the supply, right? So increase the ability of eye banking to flourish and prosper in different parts of the world. So I think that, we have to do one thing or the other, but as a group of cornea specialists, we just can't sit by and see all these patients who have reversible blindness who cannot be treated. So I think that we need to do something. Yeah.
That's a perfect segue. Thank you so much for that. Exactly. And you pointed out something very important, which is that we're talking about reversible blindness. So glaucoma, macular degeneration, irreversible. After cataracts, cornea opacification is the second leading reversible cause of blindness. So thank you so much for your thoughts about that. And you also touched about something else that I think is important, which is, as physicians, we're so used to treating patients as an individual. And it's really hard for us to see outside of that. But when we're talking about cornea transplantation, you have to think bigger and as a public health problem. So we're trying to think what's best for a population. And I constantly feel this conflict within myself, also because in a perfect world, I'd want to give everyone a cornea transplant. So there's a lot of, like you brought up, ethical conversations to be had. So this paper written, it was published by JAMA Ophthalmology in 2016. I consider this like a landmark paper for corneal blindness. This is a map showing the leading indications for corneal transplants by country. And they went individual into every country, and the white ones, there wasn't enough data. So as no surprise, in North America, it's the leading indication for corneal transplant is going to be Fuchs dystrophy. But in a majority of the world, it's going to be something else. If you look at India and China, you see infectious keratitis. The darker pink, you can see that's going to be keratoconus, a lot of Latin America, Northern Africa. And when we're talking about corneal blindness here, we're talking about severe scarring that is vision threatening. And of course, we know that Fuchs does certainly impair our vision, but how many patients do you have with Fuchs that are actually blind from it? It's not as much. So this is really severe scarring that we're talking about. So my next question is to Dr. Khandelwal. How would you rate the patient impact of Fuchs versus corneal scarring from infectious keratitis as a cause of corneal blindness?
Well, like you said, Fuchs oftentimes is progressive, gradual, with maybe, we're talking about fuchs specifically, not necessarily bullous keratopathy from something like a tube shunt. And so, in that way, patients sort of learn to accommodate as their vision decreases through the years, much like a cataract, like a nuclear sclerotic cataract. But I always imagine something like corneal scarring from infectious keratitis to be like that PSC that comes out of nowhere, to give an analogy, and patient's vision goes away quickly and they don't have time to adapt to it. And the pattern on there is it's tough, because I think part of what we have as an advantage here is such great access to fortified antibiotics, or access to scleral lenses, various things that you can do, and it's challenging to see that infectious keratitis can be such a debilitating disease in some of these countries where they don't have access to some of the stuff that we do, because we don't see infectious keratitis in most cases causing this type of severe scarring. Some go through and end up scarring, but many can be treated.
Great point. I mean, that's why this topic is so complex, because like you said, access to antibiotics and stuff, that definitely comes into play. Thank you. So there's no organization really keeping track of the types of transplants performed worldwide, but this is some good information that we have from the EBAA, which is, how is the tissue that we're exporting from the United States being used? And the point I want you to take from this is that a majority of the tissue, about 2/3 here, is being used for PK. So that's very important, because any alternatives that we have, we need to think that, can it replace a PK, which is what most of the world needs. So the bottom line of what I talked about so far is that corneal blindness is prevalent worldwide and disproportionately greater in developing countries. And there's two steps of what we need to do. We need to first determine the greatest barriers to obtaining treatment. And then number two, explore alternatives to traditional corneal transplantation, which will address the current limiting factors. So my next question is to Dr. Rostov. What do you think are the greatest barriers to successful corneal transplantation in developing countries?
Thank you, Priya. Great presentation thus far. And this is one of my areas of passion, basically, as I'm sure you know, having done a lot of work in India and Nepal. There are a few barriers, but one thing I think that we need to look at is the corneal ecosystem. Okay, so there's the issue of access to tissue and eye banks. There's training corneal surgeons. But as we are trying to help establish eye banks to be self-sustaining for tissue, getting consent for the tissue, making people aware about the importance of donation, processing the tissue, and training surgeons, there's still basically an open tap, right? There's just a huge influx of corneal blind. And so we also have to think about the prevention portion to help prevent corneal blindness as well as treat the corneal blindness. And there's actually a very successful prevention programs training female community healthcare volunteers in rural areas to diagnose and treat early corneal injuries that can help prevent the blindness in the first place. The other thing is, so I would say one barrier, if you will, or one thing to think about is prevention. Another arm is essentially follow-up care, because even if you have the tissue and you have the corneal surgeon that's trained and the patient gets a transplant, about half, there was a study done by SightLife actually, where half of all corneal transplantation patients are lost to follow-up at 1 year. In these areas. And so I think that one of the real barriers to really good care is follow-up. And I think that, as Dr. Dhaliwal said, you really have to take a look at all of the various factors rather than just one factor. And so I would say that, yeah, it's access to tissue, it's having a trained cornea surgeon, but then also another very, very important aspect of this is access to good follow-up care. Patients can't get drops necessarily or have the means to see somebody.
Right. And that's where takes me perfectly into my next slide. So the goals, the first part of what I wanted to do was to better understand what are the barriers. It's so complex, this issue. And what I did along with my mentor and now co-investigator, Dr. Akpek, is that we broke it down into 11 steps. You know, we want to determine which factors are really preventing or limiting widespread corneal transplantation. We talked about donor factors, recipient factors, the tissue, whether the eye bank, the transportation. We broke it all down. And what we did is I love the word that you use, which is ecosystem. I think it's very appropriate because each ecosystem needs to be analyzed separately. And so we want to focus on one ecosystem in particular and ask the corneal surgeons in that ecosystem what factors are really preventing them, holding them back from treating these patients with corneal blindness. The country that we chose to study was India. And I really love this map, and this was published in 2012, and it's showing two things here. The size of the country indicates the population of patients with corneal blindness. So as you can see here, India is huge. And the color is the country readiness. So what is the readiness to be able to do cornea transplantation? And the way that they determined this was how many cataract surgeries they're currently doing, the rate of it. And that's important because before you do cornea transplants, you need the necessary infrastructure. So we thought India would be a great first place ecosystem to study. And the reason is because there's a great need for corneal treatment. And number two, there's a good infrastructure already in place. So we designed a survey to administer to the corneal surgeons in India. And the purpose of it, one of the purposes, was to identify the greatest barriers and challenges to perform corneal transplantation in India. We administered an electronic survey and we sent it to all the listserv for the Cornea Society of India. And we did it over a period of 6 months. And what we found was the number one challenge that cornea surgeons reported was that there was difficulty in finding donors who fulfilled the screening criteria. At least half of the surgeons reported that this was an issue. Number two was the donor willingness to donate their organs. And number three was the ability to store tissue after it was prepared. And so the first reason, this is something that we can work on with alternative methods to keep in mind. Number two is a little bit harder. This donor willingness to donate their organs has to do with cultural and generational. This takes a few generations, I think, to really make a change here, but something that we can keep in mind, but it's harder to make fast change for number two. And number three, ability to store tissue after it's prepared. This is also something that we can keep in mind when we think of alternate techniques. And the reason why this is important is because of any alternate methods of corneal transplantation should address the greatest barriers in that particular ecosystem. So I'd like you to keep that in mind. And we will be presenting this at the ASCRS meeting if you're coming to that. So I talked about the first part of our goals, which was to determine which factors in India were preventing widespread corneal transplantation. And number two is explore alternatives to traditional corneal transplantation. And there's been quite a few studies in looking at all of these alternate methods. And there's a lot being done about artificial synthetic cornea right now, which we see in the news and in journals as well. The one that I'd like to focus on today is sterile cornea. And this can be either sterilized through gamma ray or E-beam. It's just the way that it's sterilized. But this is what I'd like to focus on as really a possible solution. So sterile cornea, what is it? It's the cornea that can't be used by the eye bank, typically because there's not enough endothelial cells. It can be sterilized and it can be used for later use. It comes in many different forms, as you see here in the bottom, with the scleral rim, full thickness. It can be K-Pro or split thickness, half moon, and it's stored in albumin. And the sterile cornea really expands our donor pool because now all these tissues that we normally wouldn't have used, we can now increase the eligibility of donors that can be used, just like Dr. Dhaliwal had mentioned a little while ago. Sterile cornea has similar physical and biological properties to fresh cornea. And one of the best things about it is that it has a 2-year shelf life at room temperature. And this is a game changer for, especially in hot climates or places where there's not as much great access for transportation to take tissue from one place to the other. This is very, very important. Potentially fewer antigens because of the sterilization process. And so out of the top 3 barriers that we talked about, this addresses 2 of them. Number 1, you can use the tissue that you would have usually thrown away. And number 2, there's no special storage required because of the 2-year shelf life at room temperature. Sterile cornea can be used in many situations. It can be used in infection, non-inflammatory corneal disease, and inflammatory or autoimmune corneal disease as well. We're going to go into that. So case number 1, this was my first time that I had seen sterile cornea. So this was when I was in Guatemala. And this is one of the patients that I presented. So he was a 47-year-old farmer. I'll never forget this. And he came in and he had actually been injured a week ago. And of course, he waited a while and then he traveled 2 days, by foot to get to this clinic and to be treated. And we could see clearly that it was going to need surgery. But before I go there, so my question to Dr. Khandelwal here, what would you do in the United States if this patient walked into your practice?
Well, I mean, because it seems like the perforation looks too large to glue, because usually we try to glue everything to get them to the next day, to get them tissue ordered. We actually sometimes will use like a halo patch graft to cover it in an emergency situation, especially if it's not central, in order to kind of patch that particular area, which I think is a type of sterile sterile cornea. But I mean, the challenge, of course, in situations like this is getting the operating room time and being able to get the patient sedated and all of that. But that's generally what we would do in our practice if this patient walked in.
Exactly. And that's, we try to glue as much as possible. And if it's not possible, then we'll have to go ahead and do a graft. And typically, when we need a graft, we may have to wait until the next day or at the most the day after that, but we can get the tissue. But what do we do if we have no access to fresh corneal tissue? And this is what happened to us there. We tried gluing over again, just crossing our fingers. Scleral patches, that was my first time that I had seen that. And so that's also a possibility. And what I realized also in these settings is that, the doctors never throw away any type of tissue, even from old transplants. They would save it because you used everything that you had. And so very limited options. And this was very distressing to me because it was my first time realizing that this was a big problem. What do you say now to this 47-year-old? I mean, that was very difficult. So what I did was, from Guatemala, I actually called Dr. Akbeck. At that point, I'd known her for many years. And she told me about the sterile cornea. And she sent it to Guatemala, which is great because we were 6 hours away from the closest airport. So because you didn't need special cold chain monitoring, she could send the sterile cornea to us. It got to us in a few days, and we were able to do the transplant. And here's a picture before and afterwards of what we did. So as you mentioned, follow-up was the hardest. So we saw this patient up to 6 months as the surgery. And Dr. Samayoa in Guatemala is the one who did the surgery, and he did beautiful work. And so he did see the patient 6 months after surgery, and we saw that the graft did remain intact, it epithelialized, it did opacify, but the patient at least had functional vision, and there was no recurrent infection, importantly. So at Wilmer, we've done use this for infectious keratitis as well. This is a patient who had HSP keratitis, and we wrote a case series of some of these patients who we used the sterile cornea for. This patient here had a great outcome. And then some of the advantages to using sterile cornea in this setting of infectious keratitis is that it can provide tectonic support, and then you can do optical keratoplasty at a later date. Sometimes when you do these TPKs, that eventually they're going to need another surgery. So this can provide that structural support until you can do optical keratoplasty down the line. In a place with limited tissue, we'll reserve fresh tissue for patients who may have better prognosis. And sometimes we have to make this difficult decision as surgeons about who may have to get the resources, who's the better candidate for it. And this could be available both domestically and internationally. This is a second patient. Okay, so 87-year-old female with a presenting perforated corneal ulcer. So this patient actually presented to my husband Joaquin, who is also a cornea specialist. So this was a Friday 4 p.m. ulcer patient, followed by for a few weeks by an outside optometrist for corneal thinning, unknown etiology, had a past medical history of rheumatoid arthritis and fibromyalgia. And besides this corneal thinning, no real other corneal history. I don't have a picture of how the patient looked before, but this is a very similar picture of how the patient looked. Minimal pain before until they perforated, and there was no infiltrate. So my next question is to Dr. Dhaliwal. What's on your differential and what would you do next for this patient?
Thanks, Priya. So, these are classic 4 p.m. Friday consults, right? And typically she's rubbing her eye because it's irritated and a gush of fluid comes out. So, we've all seen these patients and they're challenging, right? She's 87 years old. She has autoimmune disease. It's not properly treated. She has severe dry eyes. And these are classic, right? These are classic sterile melts right in the center of the cornea. So what we typically do is you want to optimize the best you can and look at the whole situation. How much perforation was there? We would try to, temporize, glue this cornea and put a contact lens on, optimize her systemic immunosuppression, optimize her corneal, ocular surface wetting so she has more ability to heal, and then see the status of the fellow eye as well, right? Because having a corneal transplant is not an easy thing, even in the US when you're 87 years old. And, is she crippled from rheumatoid arthritis? What's her overall status? Is she wheelchair bound, et cetera, et cetera? So there's so many things to think about, but the first thing we would do in these situations is try to temporize and optimize, again, the ocular surface and her ability to succeed and heal when you do stage 2, which would be sterile cornea. I'm just guessing.
That's exactly right. I love, thank you so much for that introduction. You took all the words from my mouth. So a lot of, aggressive lubrication, obviously this is not controlled. Rheumatoid arthritis as well. They need to be systemically treated as well. So put them on steroids. And with these type of patients, just like you said, you try to glue again, try to hold off surgery until they're a little bit in better position for it. And that's exactly what we did here. We glued, it didn't work, we glued again, tried everything. And ultimately, sometimes you may have no choice, but you may have to go to surgery. But at least at that point, they have some steroids in their system. You've already talked to the rheumatologist. And here's a picture showing, afterwards, we used the sterile cornea in the setting, which was just on the shelf. It was very easy, right? We had it right there available because the glaucoma surgeons use the sterile cornea for their. And here's a picture of the patient post-op day 1, and we had an anterior chamber that was formed. In this particular patient, our goal is tectonic support. They had limited visual potential, so no further corneal surgery was done, but we achieved our goal of tectonic support. And one could argue even there's less chance of rejection, so it could be better even than fresh tissue in that way.
These are challenging because you don't know quite how deep the tissue goes. And so, it seems like something superficial you can just take right off, but oftentimes the tissue is sort of involved and much deeper than you think. And that's why you have to be prepared. And we're so lucky because we've got, ability to perhaps do some imaging to look at depth. And a lot of times, if for a patient, we've got options even in the operating room where we can have backup tissue as an example. We can even have, variations of tissue available. So we're so lucky in those options. But I certainly, in a place where tissue was limited and maybe even OR instruments were limited, you'd have to really carefully counsel the patient.
Exactly, right. And so this is a patient at Wilmer that we had, and we did the sterile cornea. We used the half moon split thickness. Luckily, it wasn't too deep. Like you said, that's the challenging part about these. And you can see in the bottom right picture, the patient did beautifully. It remained clear for up to the 1-year follow-up that we saw the patient. Dr. Fogla in India has been really one of our main collaborators who has worked in the sterile cornea with us, and his cases are also published in our case series. And as we all know, he's a leading expert in DALK, and he's been using this tissue for his DALK surgeries. So here's a 22-year-old patient that had macular dystrophy. And our surgical options, as we know, you could do a PK or you could do a lamellar keratoplasty. And here's a before and after picture of this patient. He used the sterile cornea for his dog, and you can see a beautiful result here. And that's a 2-year picture. For the 2 years that he followed up the patient, the graft remained clear. And he's done this for different stromal dystrophies as well as keratoconus. He's used the sterile cornea, and the patients have really done beautifully. And I think it's important to talk about, using sterile cornea for non-inflammatory disease. Up to this point, I've been talking about using in emergency situations, which I think is very pertinent in worldwide global corneal blindness. But there is an advantage talking about it in this setting as well. They have similar outcomes. There's a lower risk of allograft rejection, lower risk of infectious transmission, and also in the setting of when there's limited tissues, oftentimes these patients are forgotten. If you do have fresh tissue, you're going to give it to the emergency patients. So if we're utilizing tissue that would have normally been discarded, then we can start doing surgery on these patients with kind of these chronic conditions in countries where they may have limited access to tissue as well. So my conclusions about what we talked about today. So corneal blindness is one of the leading causes of blindness worldwide. And there's such a discrepancy between the magnitude of corneal blindness and the number of corneal transplants performed. And like what was mentioned before, I think it is a responsibility of all of us cornea transplant surgeons to think about this and what we're going to do in the future. The most important barriers that we found in India were donor-related factors, particularly fulfilling the screening criteria and the willingness to donate, as well as the ability to store the tissue after it was prepared. Sterile cornea would be a great option potentially in India, and because it addresses 2 out of those 3 barriers that we talked about, and we think that it could be helpful for other countries and regions as well. Sterile cornea can be used for a wide variety of diseases, including infectious keratitis, inflammatory and autoimmune disease, as well as non-inflammatory corneal opacification, like using it for DALK in the setting of keratoconus or stromal dystrophies. So my last panel question is to Dr. Rostov. From your experience, I know you have extensive experience with Sight Life and I've read a lot of your work, are there any countries that you feel that may benefit from the sterile cornea?
Yeah, I think that a lot of countries could certainly, there are so many under-resourced countries in terms of benefiting from sterile cornea. I think that Ethiopia is a prime example. Ethiopia does have an eye bank. I've worked helping to train some of the cornea surgeons, in fact, in Ethiopia. And I think that that's one place that, right top of mind that would benefit extremely, aside from, what you've just mentioned as well. A lot of places as well in South America, it sort of really depends. Central America can also benefit, but top of mind, I would say probably Ethiopia.
Great. So I look forward to connecting with you later then about that. So special thanks to Dr. Akpak, Dr. Fogla, Dr. Semayoa, he's in Guatemala, and Joaquin, my husband, for all their help and collaboration and surgeries that everyone here has performed. Here's a picture of my 2 kids. And here's my email address as well. I'd just like to thank again the Rising Stars organizers for this opportunity to present something that I care so much about, and thank the panelists for their comments, their advice, and I look forward to connecting with all of you in person, hopefully sometime this year.
Yeah, that's been exceptionally different, passionate, and what a wonderful way to present this very, very touchy yet important topic. Because globally, I know, I mean, I'm sure that Audrey has traveled much more than me, but I've also traveled a little bit to, states, to countries like Africa and stuff. And it is an exceptionally large problem once you go down on the floor. And I'm sure that you've seen it yourself in different parts of the world. Definitely alternatives to traditional transplant is going to be the way forward. And I know that a lot of conversation that have been happening in terms of endothelial cells, injectable cells. Those are probably different ways that people are, already thinking in different lines, synthetic corneas, so many different ways that people are, discussing this. And I know Deep gave a really good lecture on DSO itself. Don't even transplant. I mean, so there is so many plethora of options available, which people really want to know. And probably want to know the incidence of how the indications of where you can use them, where you can't use them. So topics like this in the Rising Star series become exceptionally important to us. So thank you so much for that. Also wanted to, you gave a whole global incidence and prevalence of corneal disease, which I'm pretty sure that a lot of the ophthalmologists don't know, including myself. I learned a lot more today from that slide itself. And the causes of corneal disease, why it's happening in one country over the other, and what's the incidence of Fuchs versus infectious keratitis. So many things. Sterile cornea is going to be exceptionally important, especially where accessibility to this kind of, to transplants is low. Unfortunately, certain governments ban the use of corneas itself. That's a big problem that countries are facing. The other issue is a lot of countries don't export corneas outside of their country because they want to fulfill their own requirements within the country, and India is one of them. So so we do face those challenges as well. And when groups like this come together to discuss these kind of matters, it only takes it one step up. That's where we want to head. It's a really good discussion to have. Thank you so much for bringing up such an important topic on this platform. I would love to, I know I would love to go on for another half an hour with this, but keeping everybody's time schedules in mind, and also the audience have a 45-minute attention span on webinars nowadays. We just like to close with thanking everybody, from the celebrity panelists to Priya, yourself, and Jen. I couldn't have done this without you. Sponsors, thank you so much for being there. And Bill, I know wherever you are from behind, just thank you so much for doing what you do. Neil, thank you for staying and watching this series with us. And everybody from the backend team, Narayan and whole team, thank you so much. And until next time, don't forget that this series will be available in the next 48 hours on our website. And watch it. We'll be happy to share more of the snippets of this episode in our upcoming social media platforms on all Instagram, Twitter, LinkedIn, and any other platform that we are present on. Thank you so much, guys.
Thank you. Thank you.
Thank
Great
you.
night.
Happy New Year, by